Hi, this is Dr. Bernstein with our October 2019 teleseminar. Before we get started, I want to give you the usual warning that my answers to your questions are generic answers. I cannot know your full medical history. I don't know all the drugs the questioner may be taking. I haven't done a physical exam on him or her, so the answers are hypothetical and should be given to your physician because he knows you better than I do. The main reason for answering questions is for general information for the listeners so that they'll know more about the physiology and treatment of diabetes. Before we answer questions, we have two special subjects. The first one relates to the recent announcement by Eli Lilly and Company of a nasal administered glucagon. Now, as far as I can tell from their advertising and from press releases, they're advocating that it be used by diabetics to raise blood sugar if their blood sugar is too low. This is only a half-truth. It should only be used if the patient is unconscious and incapable of consuming something by mouth voluntarily. If the patient is semi-conscious, it probably would be a valid application also, but for someone who is cognitive and can do what you ask him to do, he should be drinking liquid glucose, or if he doesn't have that available, chewing a glucose tablet. To administer glucagon to someone who does not really require it brings with it some problems. Glucagon works by telling the liver to convert the body's stored glycogen, which is a starch, back to glucose, thereby raising the blood sugar. However, once you've administered glucagon, you've used up much of the body's stored glycogen. So if another hypoglycemic episode occurs later on, hours later or days later, I shouldn't say days, but hours later, there may not be enough stored glycogen to make another dose of glucagon effective. So that's one hazard. The other hazard is a fairly significant incidence of nausea from the administration of glucagon. Now, the provider information says that nausea is a side effect but very rare. In my experience, it has not been very rare. It is a significant percentage of the applications of glucagon for hypoglycemia. So this is a fine idea. If you have an unconscious patient, you could literally squirt this stuff in his nose. You don't even have to tell him to inhale, because if he's still breathing, it'll get there. And it takes a while to work. According to the manufacturer's literature, however, it takes as long as oral glucose would take. So if the patient is conscious and can drink some liquid glucose, that certainly is the preferred route. And of course, liquid glucose is far, far cheaper than glucagon. Our other special subject relates to a study of epileptic children who are being treated with extreme ketogenic diets, where they have to have their blood ketones continually grossly elevated. This recent study shows that 17% of children, I believe ages 4 through 7 years, develop hypothyroidism after 1 year of a ketogenic diet. Now, the study has not been extended yet to 2 years, so it could be that even more kids will develop hypothyroidism after 2 years on a ketogenic diet. I've been, for years, advocating against ketogenic diets for the treatment of diabetes, usually because they deprive kids of protein or adults of adequate protein. But yet this is another reason why you should not be following ketogenic diets, and certainly not for children. Our first question. I'm a healthy 77-year-old, high-risk heart patient with type 2 diabetes, having an A1C of 7.6%, which is an average blood sugar of about 200 milligrams per deciliter. Is the evidence compelling to include Jordance, which is an SGL2 inhibitor, in my all-insulin diabetic medication regimen to reduce chances of cardiovascular incidents? Well, this is a wise question because there's been a lot of advertising and also promotion by the American Diabetes Association that these SGL2 inhibitors protect you against heart attacks. My recollection, which may not be exact, is that they may reduce the incidence by about 20%, which is not a huge reduction in incidence. But I also warn people that these SGL2 inhibitors may have other adverse reactions. And as I announced last month, they've been found to grossly increase the incidence of amputations in diabetics. No reason given, but this has been an observation. So there are problems with the SGL2 inhibitors, and if you're, doesn't matter whether you're type 1 or a type 2 diabetic, I am not recommending them. If you want to reduce your chances of a heart attack, work on your blood sugars, which are the usual cause. High blood sugars are the usual cause of heart disease in diabetics. So, and there are many things that you can do to normalize your blood sugar. Most of them are listed in my book, Diabetes Solution. So I'd say work on blood sugars and take care of those first. Don't take chances with SGL2 inhibitors for a 20% reduction. I'm a type 1 for the last 16 years. I have been on your low-carb diet for 2 months. I take Fiasp before meals. I vary the dosage of bolus insulin depending upon what I am eating. By the way, that right away tells me he is not on my regimen. I doubt that he's read my book, because we try to keep our meals constant from one day to the next. We don't guess at how much insulin we're going to take every day. I vary the dosage of bolus insulin depending upon what I am eating. I've been experiencing an increase in blood sugar in the afternoon at around 110 to 120 milligrams per deciliter. After dinner, I am often in hypoglycemia around 50 milligrams per deciliter. Chapter 18 of your book doesn't cover this problem. Oh, I guess he did read my book. Is this a basal insulin or a bolus insulin problem, or both? It's probably a combination of things. Number one, you're guessing at your doses of insulin because you're varying what you eat from one day to the next. And that's never going to work. Secondly, after 16 years of type 1 diabetes and elevated blood sugars, it's almost inevitable. I should remove almost. It's inevitable that you have gastroparesis. Gastroparesis delays stomach emptying, so that and it delays it in a haphazard, unpredictable fashion. So if you take insulin for a meal and the meal is slow to empty, your blood sugar will drop after the meal because the insulin worked faster than the meal. And then hours later, when the insulin's through working and the stomach eventually empties, your blood sugar goes up. So that's what it sounds like. And you're giving it an insulin that we would never use for people with gastroparesis, namely the Fiasp, which is a very rapid insulin. I just got through speaking to a lady less than an hour ago who has slight gastroparesis, and she mixes her regular insulin, which is the slowest rapid-acting insulin we have. She mixes it with a little bit of NPH to slow it down. So, and before that lady, I had a young lady who's taking her insulin after her meal. So to have an ultra-fast insulin before the meal when you have gastroparesis is very inappropriate. Again, you should read my book, Diabetes Solution. I am trying to locate brand name glucophage because the generics don't work for me, and the second-line drugs have caused me serious, even dangerous side effects. I contacted Bristol Myers Squibb. They advised me to call EMD Serrano, to whom they had sold the U.S. rights, and Serrano advised me that they were no longer distributing in the U.S. Is there any way I can get brand name glucophage? As far as I know, brand name glucophage is not available in the USA. I don't know if it's available in any other countries. I have not found it in Canada. My patients are now taking generic versions of glucophage, but the problem, and I'm told that there are 23 different generic versions, and they're not all the same. They may have different effects on blood sugar. They may have different side effects. So some generic versions may cause diarrhea, other generic versions may cause constipation, and other generic versions may cause neither. Furthermore, different individuals respond differently to the different generic versions, just as they responded differently to glucophage. So what I have my patients do is start with one generic version and make sure that the pharmacy writes down the brand name on the label. And if that one turns out to be satisfactory, you reorder the same brand over and over. And if your pharmacy no longer carries that brand, you may have to go to a different pharmacy, or you may have to ask your pharmacy to specially order that brand. If the first brand you try has adverse effects, you try another brand. You might use you might purchase, let's say, only a few weeks supply initially of each brand until you find one that doesn't cause problems. Another aspect of this is to, if you get diarrhea, for example, it's helpful to take the product after meals at the beginning. It also is helpful to start with the minimum possible dose and raise it as needed over time, giving enough time for diarrhea, let's say, to disappear. So if you get diarrhea with a small dose, you live with it for a few weeks, and you may be able to tolerate that dose after a few weeks, and then you raise it slightly. After 30 minutes of exercise on the rowing machine around 5 p.m., my blood sugar levels sometimes immediately drop and then 1 to 2 hours later increase. Dinner is around 8:30 p.m. Does that have an impact on the post-dinner hypoglycemia? Well, that's a very good point, because exercise slows stomach emptying. It increases sympathetic tone and decreases parasympathetic tone, but you need parasympathetic innervation for digestion. Now, if you already have gastroparesis, then exercising and then having dinner can cause this problem of delayed emptying. And you should read my book. You should probably be taking a slower acting insulin before your dinner. And for people with more severe gastroparesis, you may need to take the insulin midway in the dinner, at the end of the dinner. You may even need to take certain medications like domperidone, which you get from Canada, or you may need to grind your meals or liquefy your meals. This is all covered in the chapter on gastroparesis in my book, Diabetes Solution. I'm a type 2 diabetic, diagnosed the past summer. I had taken metformin about 14 years ago for pre-diabetes. I have developed a rash in bilateral lower extremities near ankles. Are you familiar with this type of reaction in other patients? I don't know that, well, I should say I haven't seen rashes from metformin. Anything is possible with any drug, especially allergies. So that's a possibility. But there's another thing that should be ruled out. Since you're a type 2 diabetic, there's a good possibility that you're overweight. And overweight individuals, especially if they have a big belly up front, tend to have an increased incidence of chronic venous insufficiency, which can initially present with skin changes near the ankles, which is what you're complaining of. So you should see someone who specializes in peripheral vascular disease to rule out venous stasis dermatitis. Is there a reason why you suggested Seba over Levemir during your last teleseminar? Well, I've suggested it over many teleseminars because it lasts longer. That's the only reason. And many people have trouble with the dawn phenomenon in the morning, where the blood sugars go up starting a few hours before they awaken. And the Seba is more likely to cover that with a nighttime shot than the Levemir. I've had type 1 diabetes for 29 years, so this person is a survivor. When I was diagnosed, I was told that I would not last more than 30 years. And have recently been diagnosed with congenital adrenal hyperplasia. I am on dexamethasone, which is a steroid. It's related to cortisone. I have noticed my blood sugars are harder to control and I am using more insulin. My question is, could congenital adrenal hyperplasia cause insulin resistance and weight gain? It's not in your case, the adrenal hyperplasia is generating too little steroids, which raise blood sugar, but the dexamethasone is probably causing the blood sugar elevation. It could also cause weight gain by causing fluid retention, or indirectly by raising blood sugar and causing you to inject more insulin, which could cause weight gain. So one thing that you might ask your doctor to look at is the dosing of the dexamethasone. Perhaps if for example, you're getting a rapid-acting version, you might be better off with a slower-acting version. If you're getting it a large dose once a day, you might be better off with multiple smaller doses over the course of the day, so that instead of having a series of peaks and then going down to normal, you had a more steady cortisol level at a normal value. That would require checking blood levels and checking the blood levels at different times of the day. Now, I'm not an expert on this, so you can't take my word as gospel. You should be talking to someone who specializes in congenital adrenal hyperplasia. I've had type 1 for 28 years, another survivor. My heart doctor did not help much in my pursuit to calculate my percent difference of my EKG-RR rating as you describe it in your book. Can you explain more what the best procedure is for me to calculate this important RR measurement from a common EKG reading? Well, you can't get it from a common EKG reading. You have to do it with an EKG reading with deep breathing. And the whole protocol is described in an article that I wrote. The title is RR Interval Studies. It's by Bernstein, RK, published in Diabetes Care, September, October 1984, and it's pages 510 to 513. So if you download that article, it gives the whole protocol. I might add that the protocol that I described then was for a particular EKG machine, but it can certainly be adapted to a cell phone if you can get a graphic display that you could print out. Here's another long-term type 1. I've had type 1 since 1981, and for the last week have followed your diet. I'm finding I still need 3 units for around 10 grams of carbs with this. It feels, will this reduce? I see. Okay, in other words, will he need less than 3 units for 10 grams of carbs? I need 1 unit for 8 grams of carbs, and most of my patients, except the obese ones, need 1 unit for 8 grams of carbs. So this person is requiring more insulin than we would usually expect. It feels also I need insulin even if I eat, say, no carb breakfast like eggs. Well, now it looks like this person has not read my book, because he's taking insulin to cover carbohydrate, but he's eating protein and carbohydrate at his meals and is ignoring the protein at the meals. This is the rule that the insulin pump users advocate. Ignore protein and just cover carbohydrate. That's wrong. And if you read my book, you'll see that it's totally wrong. So your problem is that you're ignoring the protein that you're eating. You think you're covering carbs, but you're covering carbs and protein. Does Lantus really depend on how many carbs I have per day? I thought it was possible to skip meals with the right dose of Lantus, but I did once and I had hypoglycemia during the night. Another person should read my book, Diabetes Solution. Most doctors and even the pre-marketing studies on long-acting insulins like Lantus give the patients more insulin than basal. Basal insulin means just enough to cover the fasting state, doesn't cover your meals. But with most of the insulins like Lantus and Levemir, the one shot a day that the manufacturers advocate usually don't last 24 hours. So they up the dose, give the people more insulin they need, so you'll have more insulin in a little blob under your skin so that it'll last longer. However, it's more insulin all day long, so it's forcing the patients to eat all day long. This was the ADA regimen where they fought my basal bolus dosing for many years, and they were giving patients one big dose of long-acting insulin a day and forcing them to eat all day long to cover the insulin. This is still being done with excessive doses of what they call basal insulin, but it's not being used in a basal fashion. So if you have no meals and you're getting an excessive amount of basal insulin, you're going to go too low. So I would recommend that you read my book, that you have, that you might not eat for a day or so to see what your basal insulin doses should be. In other words, how much insulin, how much Lantus do you need twice a day to keep your blood sugar level? You have to do experiments and follow a low-carb diet and have constant meals. That way you'll know how much to take. I've recently been diagnosed with gout. How should this affect my dietary choices as a type 2? I would think that you should discuss this with your rheumatologist. Different gout plans may be slightly different. Some require the elimination of organ meats. Some of them have you reduce the amount of red meat. There are different plans for different doctors, so contact your rheumatologist. I have terrible, nearly uncontrollable diarrhea when I take metformin for my type 2 diabetes. Is it simply orthodoxy that it must be taken with food, or can I take it early in the morning without food on an empty stomach? Or are there other ways to mitigate the GI misery? Well, I've been over this over and over. I'll mention it again. First of all, there are 23 different versions of metformin. Well, I should say different manufacturers. You could double that because most of them may have both a slow release version and a rapid release version. So the rapid release versions are more likely to cause diarrhea than the slow-release versions. All of the versions are less likely to cause diarrhea if you take it right after a meal on a full stomach. Furthermore, it's less likely to cause diarrhea if you start with a low dose, keep taking it for a few weeks until the diarrhea goes away, and then gradually elevate the dose. Now, it's not going to go away on everybody, and it's not going to go away with every brand of metformin. So it's all trial and error and experiments. I keep hearing about brown fat versus white fat. If we increase brown fat, can we cure diabetes? And if so, how to increase brown fat? Well, brown fat has a higher metabolic rate than white fat, so it sort of utilizes more calories. The thiazolidine diones, which include lactose and avandia, increase brown fat, but they also have potential problems like fluid retention. Could that reverse type 2 diabetes? Well, there have been several articles showing that very early type 2 diabetes or prediabetes is reversible with both weight loss and the use of thiazolidine diones. You could search the literature. I don't think I saved the articles, but they do exist. I take Lantus twice a day, but since they are small doses, they do not even last for 12 hours. Is there another solution other than using an insulin pump? Well, an insulin pump is not a solution because I've never seen normal blood sugars on a pump user, except sometimes early on when they're still making their own insulin. The answer is Seba, which lasts longer than Lantus. And if you look at my videos, you'll see my guidelines for how to dose Seba. I was diagnosed with MODY2, that's maturity onset diabetes of youth type 2. Now, I doubt that this is a kid who wrote the question, so it's hard to understand that he has MODY2, but maybe he's had it for years. I don't know. I can get my A1C down to 5.5 if I eat 100 grams of carb per day. However, I'm always hungry at these levels. When I raise my carbohydrate above 100 grams, I feel much better in general, but my A1C goes up to 5.7. Well, I'd recommend that you read my book, Diabetes Solution. If you want to get your A1C down, it takes less carbohydrate. Also, many people who are on diabetic diets are getting inadequate amounts of protein. So the book makes some recommendations with regard to protein. I would suggest that you read the book, lower the carbohydrate, increase the protein, and you might need to take diluted regular insulin to cover your meals. And in the book it tells how to dilute regular insulin, which can be done by a pharmacist who does custom medications. This is another MODY type 2. Fasting blood sugar between 105 and 125, that's fasting. After meals without carb, between 125, 140. Do I require treatment? I read that MODY-2 doesn't progress and doesn't damage tissue and organs. Is that true? It all depends on your blood sugar. If you have normal blood sugars, you won't get to organ damage from high blood sugars. So the game plan should be to keep blood sugars normal. And normal means, as far as if you go by the studies that have been published, around 83 milligrams per deciliter for an adult all day long. I was diagnosed with type 2 diabetes at age 44. Now at age 53, I'm starting on insulin. I am overweight, but not grossly so. Is there a good chance that I am latent autoimmune diabetes of adulthood? Should I be tested for it? If I am LADA, does the treatment differ than if I am pure type 2? I've said this over and over again. You should be treating the blood sugar, not the name. There are a host of treatments for diabetes, and they should be geared toward normalizing blood sugar with a minimum or absence of adverse effects. To treat a name implies that there's only one treatment for each name, and that's absolutely not the case. My book attempts to ease into treatments, starting with the mildest and going on to stronger and stronger approaches to lowering blood sugar. So you should be treating blood sugar and not even think about the name of what you want to call your disease. By way of example, by the way, I have clear type 1 diabetics, type 1 since childhood, who I'm giving metformin to for a variety of reasons. Yet, until recently, the ADA recommended against metformin for treating type 1 diabetes. It wasn't that there were adverse effects, it's that they just didn't realize that there could be benefits. So that's a medication for type 2 that I'm giving to type 1. Again, you don't treat the name, you deal with making things work. I'm a certified diabetes educator and work with insulin pump patients. What ratio do you suggest using to bolus for protein, and does the amount of saturated fat affect the ratio? Well, this certified diabetes educator, I'm sure, is seeing a lot of patients with wild blood sugar swings because this educator is advocating insulin pumps. In terms of the ratio that he or she asks for, I usually start with a guess at a half a unit of regular insulin for every ounce of protein. Now, if you're on an insulin pump, you're not even getting regular insulin. You're getting ultra-fast insulins that are very inappropriate for meals. If a patient with type 2 diabetes also has stage 3 kidney disease, do you continue to prescribe 30 grams of carbohydrates per day and only chicken and fish for high biologic value, limited protein, no beef, pork, egg yolk, and the remainder of the low protein diet from legumes, vegetables, and grains? If the latter plan is followed, the grams of carbohydrate are at least double 30 grams per day. Well, I don't know where this person got that plan, but the Stage 3 kidney disease is a glomerular filtration rate of 30 to 59 milliliters per minute. Now, this is less than from half of normal to about a third of normal. And I've had patients with 40% of normal, a GFR of 40, who were on the diet that I recommend in my book, Diabetes Solution, and they've maintained their GFR for years and years, treating some as long as 15 years without changes. So there's a myth that protein damages the kidneys, and this was disproven several times. The only advantage to reducing protein is that when people have a GFR that's very low, say around 5, you can postpone dialysis by several months, maybe 3 months, maybe even as long as 5 months, by giving a low-protein diet consisting of a mix, a customized mix of amino acids. So I would suggest that you probably can get away with what we recommend in my book, but discuss it with your nephrologist. We know that diabetic kidney disease is caused by high blood sugars. So keeping the blood sugars elevated is certainly going to accelerate it. If my fasting blood sugar is regularly below 120 and my A1C is less than 6, do I have to continue to take metformin twice a day, 500 milligrams? Well, what I say is what Yogi Berra would have said: what works, works. Read my book, and whatever medication does the job is what you should be taking. You certainly should be on a low carbohydrate diet. I'm a type 1 diabetic. My last A1C was 6.0, and I've been on a strict low-carb diet. However, I've not been able to lose weight. I've asked my endocrinologist about lowering my insulin dose to help with losing some of my excess 100 pounds, but she seems more interested in my numbers than in me as a person or patient. What do you recommend? I recommend you read my book, Diabetes Solution, number 1. And number 2, that instead of using an endocrinologist, you find a kindly family practice physician who will listen to reason. You could ask your friends and neighbors if they know a family practice physician whom they like. I'm a type 1 diabetic. I work long hours, 10 to 12 days. I have to jump from day shift to night shift, sometimes back and forth, within a few days. My eating times are also not consistent. While with this, I'm having trouble keeping my blood sugar constant. I use Seba and Humalog pens. Do you have any advice that might help in keeping my numbers more stable? First, read my book, Diabetes Solution. Then try to have fixed meals, like preparing your meals at home and bringing them into work and putting them in a refrigerator at work. Perhaps of greatest value would be finding a new job where you don't have such screwy shifts. I might add, by the way, that I have had patients who were hospitalists who had shifting hours, and they had a very tough time keeping blood sugars stable. But it was mostly because they ate in the hospital cafeteria and did not bring their own meals. I'm a pre-diabetic and follow the PhD low-carb lifestyle, which is very similar to your diabetes diet. This has helped to stabilize my sugars. However, my fasting sugar today was 76. What could be the reason for such low sugars when I wake up? Is there something I can do before bed to help regulate this? I am not currently on medication. Well, your blood sugar of 76 is in the normal range. It's very close to the ideal of 83. Not only that, it could well be that you're not using an accurate blood sugar meter. We currently recommend the Freestyle Freedom and the Freestyle Freedom Lite. Other meters tend to be more variable than this in the normal range. So I think you should be happy with the 76. Make sure you have an accurate blood sugar meter. In addition to the strips, I use the Freestyle Lite 14 continuous glucose monitor. I pay for it myself since I do not have type 1 and the insurance does not pay for it. I frequently see big discrepancies between the two readings. I know that for the Freestyle there is about a 10 to 15 blood sugar lag in the time. Even taking that into account, most time the numbers are way different. Which method is the most accurate? Well, first of all, if you're a type 2 diabetic and not taking insulin, why on earth do you have a continuous glucose monitor? Especially since you know already that it's not as accurate as a blood sugar meter. Well, you're asking me that question. The blood sugar meter, if you have the right meter, namely the Freestyle Freedom blood sugar meter, not the continuous monitor. The continuous monitor is not as accurate. So I would say use the meter, and you don't need the monitor. You don't have to pay for the ongoing cost of the continuous monitor. Is berberine as effective as metformin? I've used berberine on a few patients who could not take insulin because they were flyers. And it is somewhat effective. I don't think it's as effective as metformin, but it's used it that I can't be certain. Is it possible to leave insulins once introduced for type 2 diabetes? The reason for getting insulin is because you need it, because you're not making enough of it. Now, if you catch type 2 diabetes very early, there are studies that speak of prediabetes, and if you aggressively treat the blood sugars early, which may involve the use of diluted insulin, they have shown reversals. So by using insulin very early, there's a possibility of reversing the diabetes if you're still making enough of your own insulin. It's not that insulin forces you to keep taking it for the rest of your life. You take it initially because you need it. You don't take it because you don't need it. Is there a difference between the onset times and length of duration or any other variable between Humulin R and Novolin R? Not to my knowledge. They're biologically supposed to be identical to human insulin. My 5-year-old has had high blood glucose levels ranging from 5 to 15.5 millimoles per liter. And that would be from 90 to 190 milligrams per deciliter, which is about 3 times normal. Currently, no symptoms. Hemoglobin A1C is within range through strict diet. Her insulin autoantibodies are high, however, still all other tests are within range. No diagnosis as yet, however, I'm concerned and wondering what I should do. Can this be reversed at this point? Well, if your daughter is having blood sugars as high as 190, that tells me that she's already a type 1 diabetic and should be treated aggressively. I'd suggest that you read my book, Diabetes Solution, and follow it very precisely. It is possible to preserve beta cell function in many people if you keep blood sugars absolutely normal. My A1C is 5.1 following this low-carb diet. I started last July. I have lost 78 pounds so far toward a 140-pound total loss goal. Am I safe just stopping metformin? Would I be better tapering my medication off? Again, you should read my book, Diabetes Solution, and you do what works. I would probably, if it were me, I would probably taper it off, but I might not want to stop it at all if it's effective and of value. You should shoot for a blood sugar target of 83 milligrams per deciliter around the clock, and let's see if you could keep it like that. Well, thanks for joining me. I look forward to being with you at the next teleseminar.